We're moving from the head down into the chest now. We're going to talk about chest trauma. Before we get into the injuries that can occur and what you might have to deal with, we need to talk a little bit about the reason why and the mechanism for breathing. When we think about why we take a breath, why I breathe in and out, it has to do with the chemical changes in your blood. It's not about oxygen levels in your blood. In fact, you don't want to breathe because the oxygen levels are changing. That's a backup system. When we get to breathing complications later, we'll talk more about it. But just understand, we don't breathe based on oxygen levels. We breathe based on the carbon dioxide levels in our blood or the pH of our blood. That's how it happens. You have these little receptors in your brainstem. They're called chemoreceptors. They hang out in the bloodstream. And as your blood passes by, it measures the pH. And your pH has to be in a very precise range. If that range changes, gets too high or gets too low, you're going to breathe differently. Breathe faster or breathe slower. Because when I breathe in, I'm taking in oxygen. When I breathe out, I'm blowing off carbon dioxide. Carbon dioxide is a weak acid, and that's how I maintain that balance. So that's why we breathe. How we breathe is a little bit different. That's the actual mechanical activity of breathing. When we breathe, what happens is my diaphragm drops down. My chest opens up. You use the muscles in your chest, the intercostal muscles in between your ribs, to open your chest up. Well, your chest cavity is a closed space with only one way out and in. When I have a closed space and I make it bigger, the pressure inside that space goes down. So what happens when I breathe in is my chest cavity, my thorax, gets bigger. The pressure inside my chest cavity is now less than atmospheric pressure, and air rushes in. Now I breathe out. My diaphragm comes up, my chest comes in, those intercostal muscles squeeze down, and the pressure inside my chest cavity is now greater than atmospheric pressure. Because of that, air is forced out. That's actually how we move air in and out. It's all about pressure. You need to understand that for some components of what we're going to talk about. It also comes in handy with breathing problems a little later on. So let's talk about chest trauma. We'll start with the easiest one first, a simple rib fracture. Anyone who's ever had a rib fracture knows that they're extremely painful. Usually not deadly, usually not that dangerous, but very painful. What is a simple rib fracture? Well, a simple rib fracture is when you just fracture one of these ribs. Now, you have ribs on both sides, but you just fracture one of them. That's a simple rib fracture. Before people get concerned and say, well, what if I fracture my rib and it punctures my lung? We're going to talk about punctured lungs in a moment. I want you to just think about a simple rib fracture. Like I said, there's not a lot of danger here if it's just a simple rib fracture. The trouble is, it hurts to breathe. Every time you take a breath in, you're moving that rib, it hurts. That's it. So what do we do for a simple rib fracture? Palliative care. We help the patient feel more comfortable. That's all we do. If it helps to put something around it, that's great. If it helps to keep it free, that's great too. We just want to monitor their breathing and make sure that they're not working too hard to breathe. If their breathing gets harder and harder, we know that something's progressed, and then we have to manage that. We'll talk about that problem in a moment. The second thing is multiple rib fractures. This is when you have multiple ribs being fractured. Again, usually not deadly, but it is indicative that there was a lot more force involved. What that means is you need to be a lot more careful. You need to be a lot more cautious. You need to think about other problems, underlying issues. If I break multiple ribs, it probably means that there might be other stuff going on underneath that. But if I assess my patient and I don't find anything else besides multiple rib fractures, then it's just the rib fractures. Now, this doesn't mean that you're going to keep your trip going. You're most likely evacuating this patient, but I'm just doing palliative care. There's nothing else I can really do for this. I'm watching their breathing, making sure that I'm supporting them, making them comfortable, and getting them to further care. Now we get to one that is deadly and is a true emergency, and that's called a flailed chest. A flailed chest is when you have two or more contiguous ribs fractured in 2 or more places. Let me break that down for you. 2 or more contiguous ribs. That just means you have 2 or more ribs next to each other. So if I had a fracture here and a fracture here, that would just be a multiple rib fracture. Or if I had a fracture here and here, but only one fracture in each rib, also just a multiple rib fracture. A flailed chest is when I have 2 or more ribs that are adjacent, fractured in multiple places on those ribs. So I would have a fracture here and here, a fracture here and here, and then potentially here and here. And it could keep going. Why is this bad? Well, this is bad because it's going to severely restrict breathing, and it changes that mechanism of breathing that we had. Remember, everything we do is based on pressure when we breathe. If I have multiple rib fractures, that segment of rib that's no longer attached is going to move independently of the rest of the chest. If I have these fractures right here, these bones are no longer connected. What it means is that this segment has no structure to it. Every time this patient breathes in, they're going to expand their chest out. Well, when the chest goes out, because that segment is no longer attached, it's actually going to move in because it's being sucked in by the decrease in pressure in your chest. And every time they breathe out, the chest comes in, but that segment is now being pushed out by the increased pressure. This is called paradoxical movement, meaning it moves the opposite way that you should expect it. It's pretty obvious. You're going to expose their chest, look at that, you're going to see this segment moving the opposite direction of the rest of the chest. This is a true life-threatening emergency. This patient needs to be evacuated whatever way we can best get them out. Now we move into problems with pressure inside the chest. Now, pressure can increase inside the chest due to rib fractures, but it can also come from trauma from the outside. What we have is what's called a pneumothorax. Pneumothorax just means air in the chest cavity. Pneumo, air, thorax, chest cavity. If you get air in your chest cavity, it's not good because it's not where it's supposed to be. You need air inside your lungs. If we look over here, what you see is you have your trachea coming down and it goes into the lungs. Now, what you have to understand about the organs inside your body and the cavities of your body is that you have surroundings around all of them. Think about it like Ziploc bags. Each organ in your body, we'll take the lung, sits inside a Ziploc bag that's sealed up. And then all the organs in your chest cavity that are in their own bags sit inside a giant bag that holds them all inside that space. If I get air that comes into the chest cavity, what's happening is you're getting air between the big Ziploc bag and the small Ziploc bag that contains the organ. As that air increases, it's going to cause pressure, which is going to push on those organs. So how can this happen? Well, you can get what's called a simple pneumothorax. This can happen spontaneously, or it can happen from a puncture. But a simple pneumothorax just means there's air inside the cavity. How do I know that this patient has air building up inside that thoracic cavity? Well, they're going to present as anxious, nervous. They're going to have a hard time breathing. It's going to get harder and harder as the air inside there increases. Right? And it could come from a traumatic event, or again, it could be spontaneous. Nothing you can do for this. This is palliative care. You want to assess it. You want to be able to diagnose it. And if it progresses and their breathing worsens, you want to evacuate them. I can then have air that builds up in the cavity and continues and continues and continues and doesn't have a place to escape. This is called a tension pneumothorax. What this means is that the air has gotten to such a place inside that thoracic cavity that it is actually collapsing the lungs. It's not actually deflating the lung. What it's doing is it's pushing on the lung so that the lung can't expand anymore. So now your air is building up outside in this space, in between those two bags, and it's pushing on the lung so that you can't expand it and get air into your bloodstream. How do I know that a simple pneumothorax has moved into a tension pneumothorax? You're going to see more difficulty breathing. They're going to be more anxious, more changes in mental status. As it progresses, later signs, you're going to see differences in chest rise. The side that has the tension pneumothorax is not going to expand as much as the side that doesn't. A very, very, very late sign, don't wait to see this, but a very late sign is you're going to see their trachea actually slide over away from the injured side. That is an extremely late sign. What you're looking for is an increase in difficulty breathing, an increase in work of breathing. That tells you that their pneumo has turned into a tension pneumo. Again, unfortunately, there's nothing you can do for this in the field. You just need to recognize that it's happening and get this patient to definitive care. The last injury we want to talk about is what's called a sucking chest wound. A sucking chest wound is when you have an injury externally. Something comes external and pokes a hole through the chest cavity. It can either go all the way into the lung or just into the chest cavity itself, meaning it can come from the outside and just pierce that outside bag, or all the way through and pierce both bags into the lung. Well, what happens now is I have a hole in my chest wall. Again, because we breathe based on pressure, every time I breathe in, air is getting sucked in through this hole into that cavity, and it's building up pressure. I need to stop air from entering this hole because every time I breathe in, I'm going to increase the pressure in that cavity. How do I do that? You're going to use what's called an occlusive dressing. An occlusive dressing is simply something that is waterproof and airtight. You can use a plastic bag, a plastic wrapper. You can buy a commercial grade device, but you need something that is going to completely block air from entering that cavity. A person with a sucking chest wound definitely needs to be evacuated. This is a problem that can progress and progress very rapidly. What you'll notice is even though you put the dressing on there, they may still develop a tension pneumothorax. If they've punctured their lung, air will be escaping from that lung into the cavity. The nice thing, if there is a nice thing about a sucking chest wound, is that you actually have an escape hatch for that air. If you notice this patient starting to have difficulty breathing, their work of breathing is increasing, take that occlusive dressing, open it up, burp it. You might notice some bubbling coming out of the wound. Let the air escape, put the dressing back down, continue to monitor. When it comes to chest trauma, we think about simple rib fractures, multiple rib fractures, flail chest, pneumothorax, tension pneumothorax, and sucking chest wounds. Everything comes down to breathing. Pay attention to their breathing, monitor it, support it, and evacuate if needed.